For me, I think figuring out techniques that are more universally applicable to all assistants in the OR, from the medical students to your most senior surgeon or PA who's closing the wounds, is important. Knots can be variable. We see patients or physicians and assistants who are very facile, can throw knots. They lay down, they use the right suture material and get great wound closure with interrupted knots. But there's a time there. So for every minute in the OR, we also know there's an increased risk of infection. So probably the best thing that we could do is use more knotless sutures with the barb technology. We have more efficient closure, so there's less time the wound's open to the air. With a watertight closure with a knotless barb suture, there's less drainage, so potentially less hematoma, less seroma, less potential for infection. And a lot of the sutures now, or some of the sutures now, are coated with an antimicrobial agent. So again, if you have a little low dose of an antimicrobial agent close to the surface and you did get some breakdown of the wound or some entry point, potentially you could avoid an infection. So I would say the skill level of the person closing the wound, the type of suture material they use. Vicryl absorbs very quickly, PDS takes longer, can also affect that wound healing, to minimize drainage, to minimize infection.